Hello, everyone. Thank you so much for joining us today. Good afternoon and good morning. Welcome to the Effective Ways to Increase Vaccination Rates Executive Education Symposium. My name is Harlow. I'm coordinating the symposium, and I'm just going to start with a quick note on Zoom participation by attendees today. We do welcome your questions. We would ask you to type your questions into the question and answer box, which is found at the bottom right-hand side of your Zoom screen. If you click on the Q&A box, it will pop open a space for you to type in your questions. Our moderator and our panelists today will be discussing attendee questions towards the end of the session, but please do put questions in that box at any time. We are going to begin today with a welcome video from Dr. John Nkengasong of the Africa Centers for Disease Control and Prevention, and I will share that with you all before we hand over to our moderator today, Dr. Madhi.
Greetings from the Africa Centers for Disease Control and Prevention at the head of the African Union, based in Addis Ababa, Ethiopia. I would like to thank you very much for giving me the opportunity to speak at the opening of the symposium on effective ways to increase vaccinations, organized by the Columbia University and the University of Witswatersrand in South Africa. It is no secret that for us at the Africa CDC, as the continent's public health agency, vaccines have been one of the dominant topics, rightly so, since COVID-19 hit. Public health and social measures can help contain the disease, but only sufficiently high vaccination rates can end the pandemic. The challenges involved in securing those sufficiently high vaccination rates are many. First of all, having suitable vaccines available is the first. COVID-19 vaccines have been developed at an unprecedented speed, and we were lucky to have even multiple candidates that prove efficacious. But we already see that this will not be the end of our work, as variants are decreasing vaccine effectiveness and making the need for adapted products more likely. Second, equitable access to vaccines is very important. Manufacturers have been in a position that allowed them to prioritize large contracts and request large upfront payments. To deal with the challenges this creates for smaller and poorer countries, the African Union created a pool procurement mechanism, including financing support, the African Vaccine Acquisition Trust, or AVAT, which allowed all member states to access COVID-19 vaccines. Current evidence on the need for even greater vaccination rates and for boosters suggests that the task of the AVAT is not yet done. Third, delivery. Last but not the least is a logistical, financial, and social challenge, which is extremely unprecedented for our continent. Vaccinating at least 60% of the African population means that at least 800 million people must be immunized, most of which are not in the targeted group of existing immunization campaigns, and some of them doubt that vaccines, for several reasons, will be available. At Africa CDC, we are supporting our member states across all of these challenges, from short-term access through the AVAT mechanism and medium-term through Partnership for African Vaccine Manufacturing, which is focusing on saving lives and saving livelihoods initiatives, which is a great partnership with the MasterCard Foundation. In that initiative, we are assessing collaboration with member states, the needs to access logistics and especially getting vaccines to hard-to-reach places, vaccination centers, risk communication, and community engagement, research on the virus, and helping us to fill very important gaps. A particular focus of these activities is on all of the society approach, or what we call the whole of Africa approach. The magnitude of the task ahead requires that we engage and commit civil society sectors if we are to reach a target of immunizing at least 60% of the African population. COVID-19 vaccines are an investment in our population's health and our economic recovery. The pathway to economic recovery for our continent goes through access to vaccines. But the investment we are making right now goes beyond that. While COVID-19 is often top of our mind, we need to ensure we do not relent in our efforts to fight other infectious diseases. We still claim too many lives in Africa, including some of which vaccines exist. We therefore see the investments we are making in our fight against COVID-19 as an investment in vaccines for the continent more broadly. As we are building systems and processes for the tracking of vaccine distribution and effectiveness, we hope that they will, in future, increase the effectiveness of our routine immunization programs. As we are developing and implementing information and education campaigns on COVID-19 vaccines, we are building them in a way to help counter misinformation and on vaccines in general. Last but not the least, as we are driving an all of society approach for vaccination, we are doing this knowing that we are more effective together. Strong and continued collaboration between the public and private sector, non-governmental organizations, academia, and the global public health ecosystem will allow us to tackle infectious diseases effectively. I thank you once again for the opportunity to contribute in this very important workshop.
I would like to echo Dr. Nkangson's welcome this morning and introduce Dr. Shabir Madhi, who will moderate today's panel. Dr. Madhi is a professor of vaccinology and dean of the Faculty of Health Sciences at the University of the Witwatersrand in Johannesburg, South Africa, where he also leads the African Leadership Initiative for Vaccinology Expertise and the South African Medical Research Council Vaccines and Infectious Disease Analytical Research Unit. Dr. Madhi, thank you for moderating today, and I hand it over to you.
Thank you, and good day, everyone. And it's a real pleasure for me to be moderating this opening session of the series of events over the course of the week. So what we're going to be doing today is we're going to start off with a high-level presentation by Dr. Stanberry, and then we will go into a panel discussion. So I'm not going to go into too much detail introducing the guests, because if I did so, it probably would take about half an hour on its own going through the abbreviated bio sketches. As all of us know, we're in a very unique position when it comes to COVID-19 and child health. In my 25 years of experience as a pediatrician and someone that's been investigating respiratory viruses, it's really the very first time that we've come across a virus where children have been relatively spared severe consequences of infection. But at the same time, unfortunately, there's been severe disruptions when it comes to maternal and child health services, especially in low and middle income countries. And certainly a modeling that was done early last year suggested that because of the type of disruptions that COVID-19 reactions were going to have on child and maternal services, we could expect anything between 500,000 and 2 million additional deaths occurring in children alone because of such disruptions. And one of the key disruptions that was of concern was the disruption with regard to immunization programs, which each year probably saves about 4 million lives from being lost. So to discuss this today, we've got Dr. Stanberry, as I mentioned, who is the Associate Dean for International Programs and Director of the Programs in Global Health at Columbia University. Larry has served on numerous advisory boards and review panels, including serving as the chair of the Vaccine Study Section and Pediatrics Review Panel at the NIH. His current work focuses on the preparedness of child hospitals globally to prevent, detect, and respond to infections with pandemic potential. We then will provide an opportunity to each of the three panelists to make high-level comments on Larry's presentation, as well as other issues which is of interest to them. And the first of the panelists will be Ms. Simone Carter, who's based at UNICEF and is a leader on integrated multidisciplinary outbreak analytics for public health emergencies. And she provides country support to better integrate and operationalize evidence in outbreak responses. Simone played a key role in the DRC Ebola outbreak in 2018 and assisted that country, and is currently involved in assisting a number of other ministries of health in integrating data across different aspects. The second panelist is Dr. Tanimola Akande, who is currently Professor of Public Health with the University of Ilorin in Nigeria. He is a specialist in health management, and he has also served in various committees, including the technical working groups, and has been a consultant to several international agencies and partners inside and outside of Nigeria. Prof. Akande has also been a member of the World Health Organization African Regional Technical Advisory Group on measles and rubella. Then the third of the panelists is Dr. Marc Grodman. Dr. Grottman has been a leader in driving innovation in new critical areas of diagnostic testing, and has created innovative programs in the areas of cancer, genetics, and women's health. Since 1983, he has served as an assistant professor of clinical medicine at Columbia University College of Physicians and Surgeons, and serves on the board of advisors of the Columbia University Medical Center. So with those brief introductions, Prof. Stanberry, if I can hand over to you.
Thank you, Shabir. Like Dr. Genghis-san welcomed you earlier, and Ms. Harlow, I want to welcome you and wish you a good morning, good afternoon, or good evening. As has been mentioned, we're going to be focused today on childhood vaccine uptake and what has been the impact of routine childhood immunizations during the pandemic. By way of, next slide, please, Harlow. One conflict of interest to mention to you, the audience, is that I am a paid member of the Pfizer COVID-19 Vaccine Data Safety Monitoring Committee. Next slide, please. So briefly, what we're going to be covering today is outlined here. We're going to talk about the global importances of vaccines and illustrate just how important they are for not just childhood well-being, but for economic growth of nations. We're going to talk about the WHO recommended routine vaccinations. There's about 20 vaccines that can be used in children, but there's only a selected number that are recommended for all children to receive. We're going to talk about childhood vaccinations in the context of them actually saving lives. We'll briefly touch on the issue of the complexity of the vaccine schedule, because when one has a greater appreciation of that complexity, one understands how the systems can be fragile. We'll talk about the consequences of declining vaccine coverage, and I suspect later we may hear some from Simone Carter as regards what's been going on in the Democratic Republic of Congo at the moment, which is a great example of what happens when you do see declines in immunization coverage. We'll talk about the impact of COVID-19 on health services in general, and then more specifically, what have they done to childhood immunization? The reasons specifically why childhood vaccination has declined during the pandemic, and what can be done to return us to a much better place than we are currently, and hopefully even invest in ways to make this system more robust. Next slide, please, Harlow. So this was a lovely report in the Bulletin of the World Health Organization over a decade ago now, looking at what were the global importances of vaccines. And it's very apparent that, that vaccines do save lives. And in low and middle income countries where infectious diseases are a major cause of death, they're particularly impactful. And with that was illustrated in this particular report. If one can reduce mortality and morbidity associated with vaccine preventable diseases, it saves billions of dollars for communities and countries to invest in other things. It can end up improving infrastructure in developing countries, and we know for a fact that it can lower infant mortality. But along with that, vaccination helps engender economic growth. because it does lower morbidity and mortality. And it's been estimated that there's a substantial return on investment with vaccination programs. But it's pretty apparent to most people that vaccination, because it reduces morbidity and mortality, leads to an increased life expectancy. Longer, healthier lives are a prerequisite for developing wealth, and wealth then promotes health. So vaccines are a way not only to save lives and increase life expectancy, but to reduce disparities, not only in health, but also in wealth. Next slide, please. These are the 10 vaccines recommended by the WHO for use in all children. And you can see that they protect against 12 different diseases. I suspect everybody who's watching today is aware of these. Many of these vaccines have been around for a very long time: diphtheria, tetanus, pertussis, and tetanus. Measles, rotavirus is a much more recently introduced vaccine, as is Haemophilus influenza and pneumococcal vaccines. Polio has been around for a long time, BCG even longer. Human papillomavirus vaccines have been a recent introduction. And so we've got a spectrum of vaccines that we know are safe, highly effective, and save lives. Next slide, please. What kind of life-saving, what do we have in terms of data regarding mortality and morbidity associated with these vaccines? Well, I think I'll give you several examples just to illustrate why we really want to make sure that we get children immunized. The global measles deaths due to back in the year 2000 is estimated to be over 500,000 globally. And as a consequence of increased efforts around immunizing children against measles and as well as other preventable diseases, saw a drop in 2018 down to 142,000 deaths, so a dramatic decrease in measles. One of the issues that we have in wealthier nations is that we've driven these rates of measles cases as well as other vaccine preventable diseases down to levels where most people are really not familiar with them and don't find them fearful. And that's one of the reasons that we worry that people will become more vaccine hesitant, and as a consequence, we will see fewer children being immunized and see these numbers reverse, not only in the low and middle income countries, but in high income countries as well. Next slide, please. To give you broader perspective on things, when you look at deaths due to tetanus, measles, whooping cough, meningococcal and Haemophilus influenza meningitis, in the year 1990, it was estimated that there were about 1.5 million deaths due to those diseases. And by the year 2015, just 15 years later, it had dropped to under 500,000 deaths. So a very dramatic reduction over that span of time. Diarrheal diseases represent a major problem globally, and rotavirus is the largest cause of diarrheal disease before the vaccine was developed. And you can see in 1990, there were an estimated 1.7 million deaths due to rotavirus diarrhea. And by 2017, that had been driven down to under 600,000. Pneumococcal deaths still remain a problem and one of the most common causes of death. And prior to having effective pneumococcal vaccinations, 1990 being an example, there were an estimated 1.5 million deaths. And by 2017, it had been driven down to under 900,000. So we have clear evidence that these vaccines are highly effective. Next slide, please. Just some additional data in terms of modeling it out. The Vaccine Impact Modeling Consortium is an interesting group, and I'd suggest anybody interested in looking at what we can expect of vaccines going forward should look at this website. But they make the estimation that the 10 vaccines, and you see them listed here, used in 98 low and middle income countries, were estimated to have averted 37 million deaths over 2 decades. But importantly, and this was published in 2021, this year, it's estimated that despite all of the setbacks that we've seen, that over the next decade from 2030, we'll see almost the same number of lives, 32 million lives saved as a consequence of continuing to use these vaccines and expanding the opportunity for children to receive them. Next slide, please. I wanted to touch briefly on the complexity of the system. This is the national vaccination schedule for Nigeria, and Dr. Akande is going to speak more about the situation in Nigeria later. But the reason I wanted to point this one out to you, of these vaccines, you can see over on the far left the number of doses, and they vary depending on the vaccine, whether you need 1 dose in the case of BCG or oral polio with 4. You see also next to that, the column says when they have to be given. So that not only are the doses different, but the age at which the child should receive the vaccine are different. And we need to stay to these schedules to get the maximum benefit of the vaccines. If you move further along to route of administration, they're not all given intramuscularly, some intradermally, some subcutaneously. So that's a challenge because that suggests that not just everybody can come and give these vaccines. You need to be able to be trained on how to appropriately administer them. The dosage is going to vary, and where you actually do the immunization, the arm, the oral cavity, the thigh of the thigh. So the point of this slide is just to illustrate to you, you need an infrastructure, you need trained people who are going to be able to administer this, you need the vaccines to be available. If you have issues with regard to supply chain, if you've pulled your healthcare workers off of immunization clinics in order to provide care elsewhere, inpatient units perhaps, or they themselves are ill, then your system's going to be fragile and you're probably not going to have as many sites where children can receive the vaccines. Next slide, please. So what happens when you do see declines in vaccination coverage? And this is just a few that I pulled off of news reports, and there are countless other ones which you can see. Again, Ms. Carter is probably going to speak perhaps about the measles outbreak in the Congo. But 2020, there was an outbreak. There was a measles outbreak in the Netherlands back in 1999 and 2000 because of low vaccine coverage. There was an outbreak in Minnesota, which was the worst outbreak they had experienced in 30 years. And they felt that was due to vaccine deniers. And that happened in 2017. Pertussis outbreaks were blamed, it was blamed on low vaccination rates in Utah in 2012, a big pertussis outbreak in Ethiopia in 2017. And then more recently in 2019, a polio outbreak in the Philippines. It was also attributable to declining vaccination rates. The point of this is that if we don't maintain vigilance, these diseases, with the exception of smallpox, have not gone away, and we have to continue to immunize in order to protect children. Next slide, please. I recognize that there could be people in the audience who've not seen cases of measles or pertussis. And I thought I'd just show you a brief slide on what pertussis looks like in a child. Harlow, can you run that one? Can you turn the volume up? Yeah, thank you.
Small birds, that's it, good girl. Keep your hand up, keep your hand up. It's okay, it's all right. Daddy's here. Keep your hand up, hand up. Daddy here. I know, little breath. Little breath, that's it. Puppy, it's okay. Breathe slowly, breathe slowly.
Hey, Harlow, thank you. If we could return to the slide deck. By the way, that kind of a cough continues for days. And so one can appreciate why pertussis is such a dreadful disease. There's very little we can do in terms of treatment, so prevention is our only real strategy. One of the biggest problems we've experienced during the pandemic has been its impact globally on health services. And it's been estimated from a WHO report that 90% of 105 countries who had reported some disruption in their in health services, with routine immunization services being perhaps amongst the most frequent. And there are a variety of reasons for that. The next slide, please. These are data from the preventepidemics.org group, the PERC report, that looked at 19 African countries and asked respondents in these surveys, one done in August of last year, the other in February of this year, had they need to skip healthcare services in the previous 6 months. And if you look all the way over to the far left, you see all respondents. And so in August of last year, 44% of respondents said they had to skip services. And by February, it had declined some, but still about a third of all individuals across these 19 African countries had to skip services for a variety of different reasons. And you can see across the 19 nations that the frequency with which respondents were reporting they skip services varied enormously, with Tunisia and Sudan, people finding it necessary to skip for one reason or another. And other places such as Ethiopia, the frequency was much lower. Next slide. As a consequence of that, during the pandemic, in a report coming out of UNICEF, where Ms. Carter works, and the WHO, estimated that there were 23 million children missed on basic immunizations last year, and 17 million of them received no vaccines whatsoever. And I won't belabor the fact that we saw a reduction in all vaccines, but this gets to be problematic. Measles immunization, if it drops below 90%, there's a risk. And you can see in this case, the measles vaccine rate dropped from 86 to 84, and that can be really potentially problematic. Next slide. Not only were there individual clinics that were being closed, but there are often mass immunization programs that are developed to help with catch-up. And in this case, we know from the WHO report that there were 57 postponed mass vaccination campaigns in 44 different countries, leaving people still increasingly vulnerable. Next slide. These were the nations that had perhaps some of the greatest struggles with addressing childhood vaccination. These are data on which countries had children that had failed to receive their first dose of diphtheria, tetanus, and pertussis vaccine. And you can see with India back in 2019, there were 1.4 million children who had missed that first dose, but that skyrocketed to over 3 million during the pandemic. And you can look at these other countries and see they were also struggling to make sure that the child received, in this case, their very first dose of DPT. Next slide. Oh, back up one. Thank you. It wasn't just low and middle income countries that struggled. These are data from the Centers for Disease Control, looking at what was happening in terms of immunization rates over 10 different regions of the United States, and you can see them there. They range from New York City to Idaho, and the curves indicate that the rate compared to what it was pre-pandemic dropped dramatically. You can see in the early April, it reached almost 100% reduction in immunization. So it was, nothing was being given at that point as the pandemic raged. And then there was a slow recovery. A second wave hit and it dropped again, and then it rebounded. But while this, and I'm going to show you a global picture of this later, what it's looking like around the world, this kind of a pattern was not unusual globally. But what's important is that while in the case of the United States, we've returned to near pre-pandemic levels in most areas, that's not sufficient in order to provide catch-up for the children who missed vaccination. So we need to have that curve well above the line that you see running across the middle of that slide. Next slide, please. The other one I wanted to tell you about is about the state of Texas. I'm from Texas, so I can tell you that most people in Texas think they are an independent nation and behave like one, usually not with great leadership. And in this case, this is a slide looking at the percent of 5 months old children who are up to date on their recommended vaccinations between over a 10-year period on a given specific day. And what you can see is that for some vaccines, the immunization rates are at 90–80% level, but many are at the 70–60% level, which are levels that are not what you would expect in a high wealthy income country. But what you can see at the far right of this curve is a dramatic drop off. And that was what happened during the pandemic, with 47% of 5 months olds not getting their recommended vaccinations and 58% of 16 months olds not getting their recommended vaccinations. The exception to that was the first dose of hepatitis B vaccine. And we give that in the hospital at the time of delivery or shortly before discharge from the hospital. So we have very high rates in that way because most everybody is delivered in hospitals, and even in Texas. And but what was fascinating about this curve was that the comment was made that this drop could be superimposed upon increases in state vaccine exemptions. And if we can go to the next slide, I'll explain that to you. Thank you. So Texas law allows an exemption from vaccinations for pretty much any reason you want. You can say, I don't believe in them. You say, it's against my conscience, although I don't understand how your conscience has anything to do with vaccine uptake, but nevertheless, you can give any excuse and be released from the requirement for your child to be immunized in order for them to go into school. And the red line is the immunization exemptions for children attending private schools. And then the yellow line, which is sort of superimposed upon the blue line, is public schools. So you can see that people who attend private schools are much more vaccine hesitant. But what was interesting is you look at that sudden increase between 2019 and 2021, you can see that the curves had been going on a pretty straight line. And over a 9-year period, they had increased overall by about 1%. And then in about a 1-year period, they jumped another %. So what we're seeing is, and I think it overlaps with vaccine hesitancy relating to the COVID-19 vaccine, more people, at least in the state of Texas, being overall reluctant to use any vaccines whatsoever. Next slide, please. These are data out of the Lancet, a fabulous article that shows you the same kind of curve I showed you for the United States with regard to what was going on during different waves of the pandemic. And you can see the entire world experienced a dramatic drop, and none of them have seen a dramatic rise and sustained increase above that baseline that we had seen before, which means that we're not catching up on all the children who missed immunizations. Next slide, please. So what were the reasons why childhood immunization declined during the pandemic? Well, when we were all told to stay on our homes, it wasn't easy to get to clinics since we weren't allowed to travel. We were limited in our ability to move about. So that was clearly what was happening during the early phases of the pandemic. There were a lot of places where there was a lack of public transportation, and that was a particular large problem in low and middle income countries. Also, a large number of vaccination sites were closed for a variety of reasons, but they simply weren't available. There was a fear, we know from other surveys done by PERC, a fear of becoming infected if they went out to visit a healthcare center. And so parents made the decision not to go out. After all, there were healthcare providers giving vaccines, and who was becoming infected? Healthcare providers. And then the issue of vaccine hesitancy that we've seen in Texas is an illustration, and probably others that are not on this list. Next slide. So what are we going to do? Well, there's a number of things we need to do. We've got to get them back operating, and we've got to be able to do that in a way that they can safely deliver the vaccine programs, both in vaccine sites as well as in mass immunization programs. We need to help healthcare workers and community leaders communicate and explain the importance of vaccinations. We need to counter the anti-vaccine efforts that are going on to the extent we can. We need to rectify those gaps. We know that there can be an urban-rural divide, that poor communities that are in remote locations are often not able to reach vaccination centers easily, and that's a discouragement to children getting immunized. We need to ensure that the COVID-19 vaccine delivery operates independently or in parallel with the childhood vaccination programs. We cannot sacrifice childhood vaccination services in order to exclusively be providing the COVID-19 vaccine to those who can receive it. And then we really need to look at what the immunization systems and programs look like and start thinking about how do we further strengthen those. Now, for the first time, we've got a global vaccine intended for use in adults at this point. And by and large, we don't have adult immunization programs globally. So it's an opportunity to build stronger immunization for programs going forward. Next slide. The other thing has to do with personnel and how we apply these systems to ensure that we get quick recovery and that we build stronger systems. We need to make sure that those people who are vaccine workers, who are putting themselves out meeting with lots of people, including children who are not going to be vaccinated against COVID immediately, and who themselves then are potentially contagious children, transmitting to healthcare workers. So we need to make sure that vaccine workers are on the top tier of those receiving the COVID-19 vaccines. We need to reopen those vaccination sites and make sure they're adequately staffed. We need to look at other ways besides the clinics to get vaccines to the people. And these have all been tried in different ways in different places. Home visits, an expensive way of doing it, but we've seen it happening here in the United States. Drive-through vaccination clinics, we've seen those. Mobile vans that can move to smaller communities. Short-term vaccination posts all over the place, banks, supermarkets, within companies. We need, in some places, to provide transportation fees. This has had a huge economic toll as well as a health toll on many families. And as a consequence, they may not have the funds necessary to actually pay to get on a bus to go to a vaccination site. And then we need to address the inequities that are existing in vaccination programs, make sure they reach all children. And then finally, I just want to say we really need to redouble our efforts, because what we're seeing during this pandemic is vaccine hesitancy is only getting more attention. With it, more people are becoming uncertain as to vaccines, not just the COVID vaccine, but all vaccines. And many of these vaccines have been used for many, many years. We know they're safe, we know they're effective, and yet people are listening to people who are clearly misinforming them. Next slide. So with that, I'll stop and thank you for listening.
Thanks, Larry, for that overview. And now if I can, without wasting time, hand over to Simone.
Hi, hi everyone. Greetings from the DRC. So maybe just flagging. Thanks so much for such a great presentation. And yeah, it really, of course, does speak to a lot of the issues that we do see here in the DRC. I think maybe just to highlight a couple of the points that really spoke out and resonated. Something, you know, as was mentioned about measles specifically, we had 460,000 cases of measles in the DRC from 2018 to 2020. And those 8,000 deaths, which were finally reported, of most of which I think over 6,000 finally were reported as children. Part of the reason that happened is because the way that the humanitarian community responds to outbreaks and public health emergencies is a prioritization and deprioritization. And that outbreak of measles and those 460,000 cases happened when we were all looking at Ebola. And UNICEF actually did publish on exactly this. We did send out a report saying, this is what happens when we take our eyes and we go, well, Ebola is the disease. We are interested as an international community with Ebola. And we deprioritize maternal child health and routine services. And this is something that we saw so heavily in that outcome. Something that positively we could say happened in COVID as a result of that was UNICEF, the WHO, and the Ministry of Health signing an agreement in the first week of the declaration of COVID in the DRC to commit to continuation of child vaccination and routine vaccination at all costs. What we have seen since has been, and this is with, we do an integrated outbreak analytics approach. We look at the health information system, or DHS2 data, and we analyze that since 2018, but the data is not perfect. So this is a caveat there. But we have not seen a reduction in the reported number of vaccines. What we need to take into consideration, this is something we were speaking about earlier, is that there are impacts on other services. So we have seen drops in family planning. And what we have seen in the last 5 months is then increases in deliveries. So an average of 7,000 more deliveries per month in the last 5 months than compared to the last 2 years, or 3 years, sorry. But no increase in vaccination. So while we're not seeing a decrease because of these huge investments, we're actually not seeing an increase, which would be responding to the increased number of deliveries, which is another factor of not having addressed the critical importance of maternal child healthcare services in the country. Interestingly as well, and again, highlighting your point about the rural areas or harder to reach areas, of course, these are the areas where we're seeing increased deliveries and no increase in vaccination rates are areas outside of high income, areas where we're more likely to see slums and harder to access areas. And so what we're trying to look at now is how can we really set up targeted programs, exactly as mentioned on, it needs to be mobile vaccination, it needs to be easier accessible, it needs to be brought to communities who are not accessing, because things like the cost of transport have greatly limit people's ability to access routine services of any kind. And so this is something that we are really trying to develop targeted programming with the Minister of Health and all of the partners, because we're not, yeah, we might not see a decrease, but if we have more children, we definitely have more children in need of vaccination. I think maybe just one other point, of course, isn't specifically on vaccination, but if we're also seeing increased rates of malnutrition. And so again, these kinds of, it's a holistic package of services, and we are, despite all of our history of knowing that this is what happens when we take our eye off of routine services and focus on another outbreak, we still are not learning quick enough from that evidence. I think we've actually seen the same, just as as mentioned at the beginning about the 2018-2020 Ebola outbreak in the DRC. We have faced in this country, since COVID, we've had 2 additional Ebola outbreaks. We have the plague in the northern part of the country. We have measles, we have meningitis outbreak, which has been ongoing now, as well as cholera. And so we've had school closures as well and disruption of all kinds of services. And so balancing a response for COVID and COVID vaccination versus the routine services, children should not be dying of the plague in 2021 either. So making sure that there are sufficient accesses to a holistic package of services for women and children is so critical. Sorry, I think my time is almost up. Maybe one other just quick point. We also did learn this as already in the West Africa Ebola outbreak. So globally, we tend to prioritize particular diseases or particular outbreaks and our responses to them when they might not be the priority of those living in the country. So many more children are dying of malnutrition, measles, and malaria than of COVID in the DRC. So really reflecting that in our programming and our prioritization of planning is so key. I think I'll stop there.
Thanks, Simone, for illustrating the multitude of challenges that we experience, and it stems certainly beyond immunization. So perhaps if I can now ask Prof. Tanimola Akande to share some thoughts.
Well, thank you very much for this opportunity to share on this the current issue on childhood immunization, particularly sharing from the Nigerian experience. Lawrence has already mentioned the serious importance of childhood immunization, the preventable deaths from so doing. In Nigeria, estimates have shown that about 40% of the under 5 mortality are from diseases that are preventable with vaccines. And unfortunately, Nigeria is a very highly populous country, and the routine immunization coverage is still low. And so we are recording a lot of under 5 mortality. In Nigeria, the driving agency for routine immunization is the National Primary Care Development Agency, which receives a lot of support from partners like UNICEF, WHO, Gavi, and so on. In the early 90s, through the expanded program on immunization, Nigeria did fairly well, getting to childhood immunization coverage of about 81.5%. But shortly after, there was a serious decline. From 1996 downwards, the percentage of children that were fully immunized dropped remarkably to 30%, to about 12%, and so on. Lawrence has already showed us the immunization schedule for Nigeria. Of course, for that large population, it means you require a lot of resources to get that done. Let me also say that Nigeria contributes about 30% of the global number of unimmunized children that are under 5. The multiple indicator cluster survey that was done in 1917 showed that about 1 in 4 of children in Nigeria, only 1 in 4 receive the recommended vaccines. And a lot of disparity in the country in terms of immunization coverage. We find that in the northern part of the country, the immunization coverage is very low. We have some states that are as low as about 8% coverage of childhood immunization. And then in the southern part is much higher. We have some states that are up to 80%. So that's the situation in Nigeria. Can Aloy, please show us the slide, project the slide on the African situation compared with Nigeria. When you compare Nigeria with the average coverage in Africa, we see that Nigeria is performing very badly. And this data is for about 2017. That in Nigeria, about 49% got their first dose of pentavalent vaccine, as compared with the 83% in Africa. The third dose, 33%, as compared with 74% in Africa. Dropout rate too is quite higher. than you have for average in Africa. And those who were able to take the first dose of measles vaccine were just about 42% in Nigeria as compared with 72% in Africa. The retainership of cats by caregivers is also very low in Nigeria. Just about 30% of more caregivers have their cats with them. Still on the issue of disparity in immunization coverage in Nigeria, those who live in the rural areas have far less coverage, about 25% as compared with about 50% in the urban area. And those caretakers who are educated, wealthy, have some and older, are likely to have their children fully immunized compared to those that have low income or no education at all. Some of the reasons that have been given for this, particularly by caregivers, for not having their children fully immunized, include lack of awareness, that some of the mothers thought, oh, the vaccines they've taken already, they thought it's just enough to have been fully immunized. And then there are also facility issues too, that attitude of health workers and supply chain issue as well. And also the issue of mistrust and fears. In Nigeria, it's a very religious country. And so there are a lot of misconceptions and myths about vaccines, resulting into much vaccine hesitancy. In addition to that, some of the challenges we are facing is that in Nigeria, routine immunization is not really prioritized because too much emphasis, well, will I say too much, is placed on mass campaigns. And so most of the resources go into the mass campaign immunization, which are delivered house to house most of the time. And that strategy in itself has brought about some complacency among mothers from accessing from visiting healthcare facilities. We also have the problem of a security challenge, particularly in the northern part of Nigeria. The northeast, the northwest now are also areas where it is difficult to access these children because of the insurgency. And we have situations in the past where even vaccinators have been killed by insurgents. We also have the challenge of missed opportunities, that some children are in the health facilities and they've missed some vaccines and yet they were not able to receive it at those visits. We also have the challenge of the multi-dose vaccine via, where in rural areas particularly, they would not like to open those vaccine vials because they don't think they have enough of children to, and then that make them have a very high wastage rate. Though Nigeria has a policy that you can open these vials, but the health workers will certainly not want to be seen to have gotten very high wastage rate. We also have challenges with data. There are data issues in Nigeria. The various surveys they come up with different results. And then even what you get from the district health information system and as DHIS2, as well as what is sent by SMS, they are quite different. So it becomes difficult to really know which one of these data that one would like to use. Like I mentioned earlier, the delivery in Nigeria of these vaccines are so much donor-driven. And so the donors will have to be there for us all the time. Otherwise, things will be difficult to get done in terms of childhood immunization. In Nigeria, there are certain strategies that have been put in place to try and reduce this low coverage. This include having Children Week, and then of recent is the NERIC. NERIC is an acronym for National Emergency Routine Immunization Coordination Center. What it does is to get donors to provide support such that secondary and tertiary health facilities, particularly in the urban areas, can provide daily fixed sessions for immunization. And then the rural areas are also encouraged and supported to be able to provide once a week fixed sessions and at least one outreach in a week. Before this, some of the rural facilities provide child immunization just once in a month. And so it increases the missed opportunities for the children. following this NERIC, there has been a steady increase in immunization coverage in Nigeria. Prior to the NERIC, which was about 33%, when it was assessed again around 2019, it got to about 54%. So that strategy appears to be working. But recently we have the challenge with COVID, just like Lawrence mentioned, that during the COVID pandemic, the lockdown prevented people from accessing facilities. And so we had the challenge of now going back, not reaching as much children as we can with this. The health workers too, sometimes they fear going to the facilities because they don't have adequate PPEs to protect themselves. And then even the clients too are scared. Just like Lawrence mentioned, the issue of transportation money was an issue. Even following after the lockdown, some cannot even afford getting into the health facility because of the economic consequences of COVID-19 pandemic. So that's the situation generally, because my time is up in Nigeria, that COVID has eroded some of our gains already on child immunization, and then we hope that we can catch up with this very soon. Thank you for having me. Over.
Thanks, Prof. Akande. I think you highlight a number of issues, including the need for countries to take ownership of their vaccination programs, but we'll discuss that in more detail. So now I'd like to hand over to Dr. Marc Grottman to share some of his insights.
Well, thank you very much. I have to commend the speakers who gave wonderful presentations and really focused presentations on just the degree and the size of the challenge that we face. I have to, and I'm humbled by their presentations and by their experiences. I will readily admit to you that I am neither a vaccinologist nor a pediatrician. My experience with vaccinations, of these vaccinations, are seeing the records transported from school to school for my children, which maybe allows me or gives me the freedom to take a bit of a different and more holistic view of what I see here. So let me reflect on something else. In medical school, we learned about that something called a Virchow's node. Now, for those of you who are physicians or not, you may know that a Virchow's node is a subclavian lymph node that's hard. That often is called that because it may be a sign of somebody having colon cancer, cancer of the GI tract, because the lymphatic drainage goes there. And it was something that was picked up, a clinical finding. And this was my knowledge of Rudolf Virchow, with Virchow's node. So I was kind of surprised to go in and read in a period of 6 weeks, the same quote attributed to Rudolf Virchow in 2 articles. One being a piece in the New England Journal that was written by I believe, a social medical person at Jefferson. And the other one was an editorial in the New York Times. It was written by Dr. Kaufman, who was head of epidemiology at McGill. One talked about Dr. Virchow, who was a physician in Germany, would bring students to the barricades of the Mars or the revolution in the mid-19th century and show them the need for social activism, and gave him credit in many ways for bringing back health practices and made Berlin at that time a model of the beginnings of appropriate public health. The other talked about Dr. Virchow as someone who spent 3 weeks going to Poland to be able to document this typhus outbreak, and what was thought to be in some way the birth of knowing that data is important to understanding disease progression and the birth of epidemiology, and goes on to talk about that, in fact, social factors are so critical. Activism, social factors. The quote that was attributed to him, that I want to be able to go get straight because I think it is worthwhile, is that medicine is a social science and politics is nothing more than medicine on a grander scale. What's the appropriateness of this? Science can be confusing. when we're told in many ways, as we've heard, for people to follow the science, in many ways it can be a twisted road. Lord knows we've lived with this recently. Right now, we've lived with this in this country over recent decisions about boosters, where science is determined by a vote of an FDA advisory committee that it goes 9 to 6 in one direction or another. We're guided by the science. But if there's any part of the science that is not really twisted, it's childhood immunizations. It's one where we can clearly point to cases of where vaccinations help save lives in Dr. Stanberry's beautiful presentation, and go by entity to entity and see where the impact of this. But it also shows that to have that positive effect, there are social considerations. And by social, I don't mean a limited view of social. By social, I mean everything which you've spoken about, which goes from the business, the money, the finances, to the infrastructure, as well as to the cultural and social tendencies and priorities of every country. And everything that we're talking about, all the success or not, is an appreciation of the entire social fabric. And where that is affected and weakens, we see the deleterious effects. So in not knowing this area, I asked my colleague, Dr. Stanberry, to tell me, what am I going to talk about? And he takes me over and says, why don't you go look at a site of real world data and take a look over what they've done and look at vaccinations. And I look at, and I see this, and we can all share it. It's an incredible amount of data, which leads me to the question of, okay, what does the Ukraine, now a lot of the data here is older, it was from 2017, and may have been updated by 2019 on different questions. You know it well. What does the Congo, Nigeria, the Ukraine have in common? Vaccination rates are all lower than 60% for on childhood vaccinations. What does Bangladesh, Uganda, and Norway have in common? Childhood vaccination rates that were close to 100%. The reality is, it's more than the economics, as all of you have pointed out in real life experiences. But it's also more than infrastructure. Infrastructure is essential. But as Dr. Stanberry brought out, we're seeing effects of where there are cultural attitudes that are having an impact as well. There's another factor, also social in nature, political unrest. Disruptions of the social fabric due to political crises, social unrest, civil strife. Those are important factors as well that are clearly critical. Some can be overcome. Some cultural feelings can be overcome. Looking at real world data, they talk about the fact that when you look about skepticism, some of the two countries that had some of the highest rate of skepticism a few years ago about child immunizations was France and Iceland. Countries that have done it relatively well, pretty well compared to the United States in terms of acceptance of COVID vaccinations. Some don't change, like some of the vaccine hesitancy and fear in Eastern Europe. Russia remains middling in both of those. The point is, we need to go understand the reasons. We need to understand why we see what we see. One size doesn't fit all. Is it money and support? Yes. Is it infrastructure? Yes. But there may be more factors. And clearly, I do want to shout out to one other point, which is the effect of immunization on refugee populations. was an article in Review about looking at work being done in the population in Greece due to the Balkan Revolution, and that Philos, a European group, would go in and talk about the ability to vaccinate, to get rates over stated populations at over 60%. But very much, as Dr. Akande said, when you then look at the follow-up based on the concerted effort on the second dose, the numbers drop substantially down. We've often talked, and certainly with Roma, Larry, and the people here at Columbia, about how children are disproportionately affected by disasters of all kinds. They not be at first readily apparent. And clearly, as you've pointed out, those countries, those societies where there are disruptions and where there's a lack of infrastructure are disproportionately affected by disruptions. We've seen that. We saw it about with COVID. I thought that Simone's presentation on the effect of looking at the effect of measles vaccination on Ebola speaks to that. The problems are multifaceted, and to go deal with them, we need the appreciation of the fact that they are. Two other quick points. As you pointed out, Dr. Akande, vaccination rates are not a one-way direction. They go up, they go down. We've seen that. And we've seen it here. And all we have to do is look at the effect in the United States on vaccine hesitancy, on measles outbreak before COVID, and on the lack and question of religious exemptions here in this country. It's not something that's safe. They do clearly can be able to vary. And the other point that I wasn't going to mention, but I had to, is the need for data. You can only understand the problems when you know what the problem is. And increasingly, the need to get accurate data on success rates and follow-up is critical. It's critical in all the things that we do. So the science in this case, unlike so many others, is clear. How we get there takes all of the disciplines and all the skills that we can muster. Anyway, with that, thank you very much. I hand it over to the panel. Thank you.
Thank you very much, Marc. So we're now going to go into a panel discussion. And just to remind people that if you do have any questions, please post it on a Q&A. And I'm going to start off with one of the questions from the Q&A. And this is directed to Larry. How can the public be educated and exposed to what vaccine preventable diseases do to children? Your Pertussis example might be highlighted to the public by TV and social media. And I think this is an issue that many places face, where we've become complacent when it comes to the type of diseases that vaccines are able to prevent, largely because of the success of immunization programs. So, Larry, what do you think needs to be done? And perhaps, Simone, if I can ask you also to comment on it, what do you think needs to be done from a messaging perspective to the general public to get them to understand the importance of vaccines? Perhaps, Larry, for you from a high-income country perspective, and to Simone from a low-income country perspective.
I'm sorry, Shabir, who did you want to start with?
Larry, yourself first.
Okay, sure. So, and this was the first one that Dr. Bergman asked, the one about having the public educated as to vaccine preventable illnesses.
That's correct, yes.
Yeah, sorry, I was having some static at this end. No, it's an excellent question. I mean, one of the excuses that I often hear for vaccine hesitancy in the United States is that nobody fears measles, nobody fears pertussis, nobody fears polio because you just don't see it any longer. I think we've done an abysmal job when we do have the outbreaks that we've seen occur in the United States not to really hammer that home. There was an example of a child who ended up with tetanus in Washington State, and who I think he developed tetanus in Oregon, and they got transferred to Washington State. And the reason that turned out to be important is that they were able to survive tetanus because they were able to paralyze and put him on a ventilator and wait until the toxins cleared. But the cost of doing that was about $1 million. And so the question became one of, should the parents be set a bill for $1 million? Even if that wasn't the case, what the child went through was terrible. And we missed a lot of opportunities, I think, in that setting, along with the measles outbreaks, the whooping cough outbreaks, to point out just what a toll this takes on children and how safe these vaccines are. So I put the blame really on the media, because I don't think we're able to get these kinds of stories out to educate people that these diseases remain. They're certainly not eradicated. There's very little we can do other than supportive therapy, and that people need to be fearful of these diseases. So my thoughts.
Thanks. Simone, from your perspective.
Thanks. Yeah, I mean, we work on a lot of different studies on perceptions and engagement with healthcare services in general, beyond just vaccination. And I think one of the things is really understanding first why people might not engage. I know we've talked a lot in all of the concepts of infodemics, and I've actually given some kind of heavy recommendations in terms of how we're very quick to assume, especially in low-income settings, that it's an information issue or it's a knowledge issue, versus it's a capacity issue. So as an example, recently, as mentioned, there's a plague outbreak. Okay, this is not a vaccine option, but there's a plague outbreak, and the automatic response is people don't know how to protect themselves. We need to sensitize communities. We need to educate communities. And actually, in many cases, they know, but they do not have the capacity to build a bed which is above ground to protect them from the I can't speak English today, from the flies that carry the plague. Same thing with vaccination. Often it is not a concern about being able to trust the vaccine or routine vaccination as much as people do not have the socioeconomic capacity to get to the vaccination place. Or this is something that we've heard in certain areas of the DRC, for example, is that vaccine healthcare workers who are supposed to deliver the vaccine get the vaccines, but they don't have the money to put the petrol or the gas in their motorbike to take them where they need to go. And so they literally cannot bring them, and they will end up dumping them. And these are things that we hear stories about, but we of course can't ever document. But the different factors in terms of how parents engage with routine immunization is often much more than just knowing. I absolutely agree on the understanding what the disease looks like, understanding the impact. And I think that that's really critical, especially in high income settings or urban settings, but often in rural settings, they're very keen and they do not have access. And to sit, for example, with parents, even in Ebola, after a certain point, at the beginning, there was a lot of distrust around the vaccine, but we promoted and said, the vaccine saves lives, the vaccine saves lives. And we sold communities on the vaccine. And then I would sit there with pregnant and breastfeeding women in tears because they had been contacts of Ebola and unable to access the vaccine because they weren't eligible. Or other communities who they had family members or neighbors who had been affected or died of Ebola, but because we were doing ring vaccination, they couldn't access it. And they said, how is it possible that you talk about a vaccine that saves lives that isn't available for everyone? And so ensuring that we are walking the walk while we talk the talk. So not pushing something that then we're not making sure that low income communities in rural areas have access to is also equally important. And then also understanding what are people's concerns. So when we look at the COVID vaccine, for example, most of the hesitancy or concerns is about information that they would like on after side effects of the vaccine. But when we look at the posters or the campaigns for the COVID vaccine here, they just say, accept the vaccine. They don't talk about the side effects. They don't talk about anything. They just say, accept the vaccine. And we expect that to work. And so we're also not providing people with the detailed information that is required. And I think that also happens often in low income settings, is that we assume that little information suffices to get buy-in. And so really, how do we work on adapted communication that meets needs, but also adapted services that that support access as well?
Thanks, Simone. Prof. Akande, perhaps I can ask you to also comment. Nigeria is one of those countries that have perennially have had very low vaccine coverage, despite it having large numbers of children die from vaccine preventable diseases. So it's not to say that there's an absence of an understanding of these vaccine preventable diseases, because parents experience it, but that really hasn't sort of resulted in an increase. So do you think this is a health systems issue, or are there other material issues at play as well?
Well, I think it's an interplay of several factors, which include the health system issue. The issue of awareness is also there, that we are not doing enough to raise awareness. And there are various channels that can be used to get this done. Mass media through radio, and it's often done during antenatal clinic attendance that the women are educated, but most times they are selective in what they want to hear. And once this information is not reinforced, then they don't go into the real practice of the behavior of assessing care. And they are also easily put off when they assess the care and the service is not the kind of quality, or they get disappointment in the health facilities. So it's not just about awareness. It's several factors that are into play here. If you get there once and you are told, oh, we don't have the vaccine today, we don't have enough numbers that we can open it, come back some other time. And this is somebody who has paid some transport money to get the money to get to the facility. And so it becomes difficult for that person to try again to assess immunization.
Perhaps we can come to you. You sort of made mention of the success in Uganda and Bangladesh, where they've really been able to get their vaccine coverage above 85, 90%, in contrast to what we're experiencing in Nigeria and other countries. Is there anything that you think is assisting those countries in being more successful with their coverage compared to countries that are still struggling?
Yeah, I think that it's an emphasis on infrastructure. I think I thought Simone's comments were wonderful, talking in about the fact is that it's just not one size fits all. There are multiple problems that are there. And if you have an infrastructure and if your priority is to do it and you can do it, whether you're a wealthy country or not, you can go it if the focus is there and the message is clear and if the people are accepting of what you are offering. I think that was the point, is that it's not just economics. The point of putting in the Ukraine in there, or was the fact that it's just not all areas of the world. The point of adding in Norway and comparing it shows about wealth. I mean, the point is that every country is different. You know what comes through here? Vaccination is local. Vaccination, you cannot go in at policies. And which is why when we talk about hesitancy in certain, and hesitancy doesn't have to be political, it's cultural. Which is why I mentioned the fear and skepticism of authoritarian rule in Eastern Europe. COVID is horrible in Eastern Europe. Vaccination is horrible there. And there's still high skepticism for childhood immunizations in many countries, and certainly in Russia. The point is that we have to accept that there are differences. And part of the difficulty in going in and coming up with, pronouncements that there's one solution is that there's not. Every country is going to be different, and we have to accept that. We have to accept it here. We have an infrastructure in this country. I do not know what the effect is going to be in parts of our country on immunization of routine diseases, where infrastructure and money is not going to be an issue. It's an appreciation of cultural differences, which is why, and my point, everything goes back to the social science.
Thanks. And it really speaks to the other issue as well that Akande actually raised, and that is an issue of government ownership. And we've seen countries such as Rwanda really make remarkable strides over a very short period of time because of the political commitment to actually get vaccination going. Whereas in many other countries, as was pointed out, they're very much still dependent on donor support to basically run the immunization programs, which comes with a whole lot of risk itself. So Prof. Akande and perhaps Simone, if you want to make brief comments with your experience as to how to get governments to take greater ownership of their own health programs.
Yeah, thank you. In Nigeria, it's unfortunate that Nigeria is seen as either rich or potentially rich. But the truth of the matter is that the funding that is available for efficient healthcare delivery is minimal. The government is not prioritizing health. They have their own different focus. And so if it's not funding health enough, when the Abuja Declaration, for example, for African ministers says at least 15% of their annual budget should go to the health sector, Nigeria has not gone beyond 5%. And so there's so much underfunding of the health sector, and therefore, all these other bits like immunization services, other service delivery are at the mercy, so to say, of donors. But how long shall we continue to rely on donors until we have good leadership that will prioritize health at all levels, not just at the national level? The same thing occurs even at the low level of the state and even the local government. So until we prioritize health and see the importance, and they also see health as not, they can't see the immediate gain, and it's because of the poor level of maybe poor level of information or available to them, or ignorance. If they're not ignorant, they will know that given immunization, for example, a lot of economic gain comes with it. A lot of deaths are avoided, but to our politicians, that's not the issue. And unfortunately, we get so disappointed, even when you have health professionals at the aims of affairs, they seem not to even have that kind of understanding to prioritize health. Thank you.
Simone?
Thanks. So maybe I won't dare to say what at the government level, being an international and working in a particular structure. What I will maybe speak to is the role as Nigeria, DRC is a humanitarian setting consistently. It is hugely impacted. The government is hugely impacted by donors and by donors and UN agencies and the political will of international actors. If the money comes in and goes to COVID, guess what will be prioritized is COVID. If the money comes in and it is the country is so heavily reliant on the international community in terms of where we put funds. And I think we have a huge responsibility in how we do that much more accountably than we do today. We, as mentioned, the quick switch between what are our priorities at a global level versus what are the country's priorities, how we respond in emergency ways versus responding in things that are much more sustainable, how we correctly reinforce health services and systems. I mean, we spend decades talking about putting ourselves out of jobs, but do we set up systems that do that correctly? Do we invest in capacity building, or if we're constantly responding to emergencies and treating the country as an emergency response, putting out fires, we're actually not supporting building that infrastructure the correct way. I think we keep learning our lesson, but we're obviously then not learning quick enough. West Africa prioritizing maternal child health, the number of women who died in childbirth or from maternal child health complications. We've seen the huge impacts of school closures in terms of underage pregnancies, in terms of sexual violence, all of the other impacts. And we have a responsibility, especially in humanitarian contexts, to ensure that investment happens in routine health services and systems. And And I think using data and evidence as much as possible and getting that out there as much as possible is also our responsibility, but then acting on it. But yeah, sorry, that's not exactly the answer to the question, but thanks.
Thanks, Marc. So Larry, perhaps if I can go to you. So one of the issues that Simone did raise in the presentation was that there's been a number of other collateral impact that COVID-19 has had on child health, including an increase in malnutrition. And at the same time, despite the decrease that we've seen when it comes to vaccine coverage, including for measles, we haven't as yet seen outbreaks resolve. In fact, for some respiratory diseases, including as an example, pneumococcal disease, both in high-income as well as low and middle-income countries have shown almost a twofold decrease, despite a reduction in pneumococcal conjugate vaccination. And influenza as an example, is something that has almost disappeared globally over the past 18 months or so. So there obviously has been an impact on these respiratory pathogens, but at the same time, there's this building of an immunity gap because of under-immunization. So do you think that the effects of under-immunization are likely to materialize in the next few months, years, or what do you think is the status in terms of the changes we've seen with the epidemiology of respiratory pathogens in relation to what we're seeing with decrease in immunization in many settings? Larry, you're on mute.
I'm sorry, that was directed to me, Shabir?
Yes.
I apologize. I'm having significant issues with the sound system at this end. Could you give me the short version of
the short version was for many respiratory pathogens, we've seen a decrease. As an example, pneumococcal disease, influenza. But at the same time, we haven't seen outbreaks of measles as yet, despite significant disruptions of immunization. And as Simone pointed out, an increase in malnutrition itself should lend itself to an increase in many vaccine preventable diseases. So how do you reconcile this? And do you think that we're likely to experience a surge in those other vaccine preventable diseases in the near future?
Yeah, no, it's an outstanding question. And the answer is yes, I think we will. You know, it's interesting. In so much of the world, we had social distancing, we had masks, we were not mingling at all. We've actually seen respiratory syncytial virus outbreaks during the summer, which is, you know, it's a seasonal virus in this part of the world, in the Northern Hemisphere, and we should not be seeing RSV in August. And as a consequence, I think that once we stop using the masks, once we start getting back into classrooms and in crowded spaces, that what you're going to see is that all of those pathogens are always with us, are going to come back. Those that are vaccine preventable, where people have not been immunized, you're going to see outbreaks.
Okay, thanks. So perhaps to Simone and Prof. Akande again. So in more so, and perhaps Larry also, and Marc, you can also input. So in many settings, and more so in low middle income countries, vaccination is seen something to be targeted mainly to children. But when it comes to COVID-19 vaccine rollout, obviously the demographic that's been targeted is very different in that we're wanting adults to come forward first. But there isn't a culture of vaccination of adults, at least in many low and middle income countries. In the high income countries, you still got a fair amount of activity going around with influenza vaccination, shingles, etc. So how do you think we can actually get this messaging across? And can we get some sort of cross-pollination to get people to understand that vaccines are not just about for children, but also involve adults?
Yeah. With the COVID-19 pandemic, in Nigeria, there was so much of social mobilization and raising of awareness concerning vaccination. And that's been the push, and also for the fear of not getting infected with COVID. That's the push to adult vaccination in Nigeria. Like you said, we hardly have people go for this kind of vaccinations. Except maybe health workers who go for hepatitis B vaccination. Adult vaccination is not very common here. So I think this is the opportunity for government and all these agencies to now use this COVID pandemic as a way to now promote the other adult vaccines so that people will now begin to access them. But the danger is with the hesitancy that we still have, the misconceptions with myths and also the rest with COVID-19 vaccine. It may be dangerous now to now put the two together, the other vaccine, adult vaccines. But maybe when the pandemic is getting down and they will see the success with vaccines, with COVID-19 vaccines, then people can then be mobilized to know that there are other adult vaccines that they can take. And also provisions made for it by government. For now, government is not making provision for it, for adult vaccination. Most people who will go for it, go into the private setup to get them get their vaccines, maybe because of travels in private places, except for yellow fever. Thank you.
Yeah, if I could add one point, I'm almost worried about the opposite. I'm worried, and maybe this is very much of a US-centric issue, and maybe there are other areas. I'm worried where suspicion, for whatever reason, about the COVID vaccination is going to impact childhood vaccinations. And that's what we saw. I think Dr. Stanberry talked a little bit about that in certain areas, the increase in number of religious exemptions that we're seeing versus in the past. And that in areas where in some way this is being mandated or being forced and is seen as a political issue and not just as an appropriate care and science issue, can lead people to be able to have more suspicion about vaccines that they didn't have before. So how you put them together is controversial on both sides and clearly needs to be understood. But there are downsides to that, clearly.
Yeah, absolutely, Mark. In fact, that was going to be the question that I was going to pose, because I think we're experiencing a very similar sort of scenario, even in countries such as South Africa, where generally there wasn't too much by way of vaccine hesitancy for children. But what we're seeing emerging currently with adults with vaccine hesitancy, including the anti-vaxxers, is going to have repercussions moving forward on how successful we are with getting parents to bring the children forward for vaccination. So a really important point. Simone?
Yeah, thanks. So, I mean, in the DRC, we had the Ebola outbreak. So we, and cholera, but less of an issue with cholera vaccine. But with the Ebola outbreak, this was also a key concern in terms of how are we getting adults a vaccine, a new vaccine, a vaccine that wasn't trusted. And I think one of the things comes again back to what does the data say? Are we collecting data which is actionable? So not just saying, would you accept the vaccine or not, but really, what do you need to know? What do you not trust? And looking at these kinds of data much more regionally. So looking at them against vaccination coverage rates and participation rates, and looking at that holistically by province or by region. So what we're doing here is, and what we've done with the Ebola vaccine was realize that one of the biggest concerns was actually that we had separated Ebola from all of the other vaccines. So I think, Marc, this kind of, it could be positive or negative. If we treat something separately, does it create further distrust? But if we bring it into routine coverage, does this then make both of them not trusted? And at the beginning with Ebola, for example, we were seeing real big concerns, parents not wanting to vaccinate their children, saying that that any vaccine was going to be Ebola and that we were going to inject them with Ebola, all of these kind of fears. That switched massively to a huge, as mentioned, a greater demand for the Ebola vaccine than we could cover. But some of the stuff that came out was people wanting to understand, what is the vaccine that goes for what age? What are the side effects? What do they look like? And why do you need them? And kind of making it just a holistic package of, these are the things that can save you and your child's life. This is the age that you get this. And this is the age that you get this. And these are the different locations where you get the shot on your body, which also helps. But really using data to understand and doing that at a local level and monitoring that at a local level to see how that works. I don't think there's a one size fits all. I think there is something about saying, like, there are, as much as possible, comparing to what is already known. So understanding what people already know and accept about a vaccine. very simply, people are very concerned in the DRC about side effects. But if you talk about the side effects of the polio vaccine, every mother knows them. And so if you destigmatize or de-dramatize these kinds of pieces of information and do a more comparative presentation of these are the side effects, this is what happens, this is normal, that also helps a lot. And we've seen that help a lot in terms of engagement with vaccine. So we are, in our case, fortunate, that's probably not the right word, to have had the experience of Ebola to act on that. But yeah, I do think it really does also require data collection and both, mixed methods data collection to develop appropriate decentralized strategies on that.
Thanks, Simone. So Larry, perhaps to return to you. So one of the striking analysis that you showed from the Lancet article is that the region that seems to be least affected when it comes to a decrease in immunization was Sub-Saharan Africa, where we look at the TTP3 coverage. I think it was about 10% reduction compared to 25-30% reduction in other regions. Do you think this is a data issue, or do you think there might be some plausible explanation as to why that region would be the least affected when you would have expected it to be the converse?
I suspect it's a data issue, as you suggest. This has been one of the challenges we've had in one of the earlier projects that we worked with Wilmont and Schmidt Futures on, and Amanda McClellan, who's going to speak later in the week. Especially across much of sub-Saharan Africa, the data reporting systems simply aren't there to give us confidence. The WHO data is really quite different in terms of how the state reports. And so it doesn't get down to that level of granularity. So I think it's a data issue.
Okay, thanks. So perhaps if I can just ask other panelists to make last concluding remarks before we bring the session to an end. Simone, starting with you.
Sorry. Yeah, I just actually want to echo on that point of data, because I think the same thing when we see no decreases as mentioned, we should always be looking as to why. I think we also need to be pushing a lot more for gender and sex segregated data, which we are not seeing in the COVID vaccine. So across multiple countries, we are not presenting data disaggregated by sex and age. And this is huge in terms of how we address campaigns to reinforce access and engagement with vaccines. Understanding who are responsible and who are the decision makers in childhood vaccination, and developing strategies which really reinforce the decision making. Often we sensitize or push mothers where the decision making at home might not actually be the mother who's blocking the engagement. So really understanding a lot more holistically the gender dimensions of how we engage and how we support uptake, I think, are really key. Facilitating space as well for learning of how this can be done across different countries, and recognizing the granularity of that as much as possible. Decentralizing as much as possible how we look at data and how we can engage the use of that better will also be key in monitoring this over time, and then using that to really advocate. I think we have talked a lot from onset. There's been lots of models published, lots of warnings published of what could happen to childhood vaccination and maternal child health in general in low-income countries. But the money is not being invested the same way as for COVID in these countries. And so that scale up really, really does need to continue to happen hopefully through data. But yeah, so thanks very much, and really appreciate the engagement and exchange on the call today. Great discussion.
Thanks. Tanimola?
Yeah, thanks for this opportunity. I think, just as I said earlier, child immunization is very important. For us in the developing countries, some are doing fairly well, but Nigeria is doing very badly. It looks like there's some hope with the recent innovations in terms of NERIC, but we are still far, far from the optimum. And so government should give some political commitment towards ensuring that people who have ready access, and then also wean themselves off donor dependency. And that's the way to be able to have a sustainable childhood immunization in Nigeria and probably in other developing countries. Again, thank you for having me.
Thanks. Marc? Marc, you're on mute.
Yeah, I'm sorry. I want to thank the panelists, and I want to thank you for moderating this the discussion. I've learned a great deal. If there's one point, is that vaccines really have an incredible impact. I mean, there are few other areas outside of the very basis of health and water, sanitary conditions that we can go look at that have an impact on the populations. And this should be no brainer. This should be a straight line. And to go in and talk about this and to see how complicated even something as straightforward can be, just gives us a sense of the challenges that we need to face. It needs engagement, but it's worth it. And I can't think of any other area that could have the same impact on changing lives as what an effective vaccine program could be done. So thank you. And it's an ongoing challenge, and it's proud to be part of it.
Thanks, Marc, and thanks, Lady Simone and Tanimola, for joining and the great discussion. And I think when, as Larry pointed out at the start of his presentation, in 2019, before the COVID pandemic, there were about 20 million children that would have been under-immunized globally each year. And with the COVID pandemic, that figure has now increased to 27 million. And the consequences of that increase in under-immunization probably remains to be realized. And it's something that we're probably only going to see over the course of the next 2 to 3 years. And analogous to what happened, in fact, in the DRC, where more lives were eventually lost from measles than due to Ebola during the course of the response to the Ebola pandemic or epidemic. Unfortunately, it remains to be seen whether that sort of history is still going to be written when it comes to the under-immunization of children during this past 2 years. So again, thank you to the panelists for the discussion, and I'm now going to hand over to Wilmot James for concluding remarks.
Thank you very much, Shabir. And so I'm Wilmot James, and the overall convener of the seminars for the week, and I'm assisted very ably by Harlow Wang, who started the program today. Thank you very much to Shabir for ably moderating today's session, to Larry Stanberry for his lecture, which was really wide-ranging and very detailed, and to our panelists, Simone Carter, who is speaking to us in situ out of one of the most complicated and difficult areas of the world, the Democratic Republic of the Congo, to Tanimola Akande from Nigeria, and finally to Marc Grodman, rounding out the panel. So colleagues, we're dealing with a model problem, not so much a science problem or medicine problem. And the model problem is particularly acute when it comes to children. So children have the same right to life and the same right to health as adults do. But they lack, because they are minors, they lack the ability, the legal authority to act in their own self-interest. And therefore they rely on others, they rely on adults to act on their behalf. And so the question is, how are we doing on that front? Not very well at all. And so we today discuss the consequences of that. And what makes it additionally a moral complexity is that we're talking about vaccinations, which is probably the greatest contribution in clinical medicine and in public health in the history of disease. And they prevent death. We're talking about vaccine preventable deaths. And therefore, there are children that will die that do not have to die. And that is a moral failure. So, but then, of course, when we speak about, as Marc Grodman did, about the fact that this is largely a social science problem, by which in part he means a political problem, is that what we are seeing is a weakness on the part of many governments to invest appropriately in health, to invest appropriately in vaccination strategies, to invest by landing it in national budgets and state budgets or provincial budgets and local budgets. Political will in the end is about landing budgets and putting that behind a strategy. That's what makes the difference. And so we have the potential through our political arena, which is really about the fight over resources. I mean, politics is a fight over resources. And what we have to do is make sure that there's a greater stake on the part of those who are interested in children's health, a greater stake out of that national budget. And for that, you need to push, you need to pressure, you need to organize, you need to have activists, you need to have a voice. And the best systems for that would be democracies, noisy, but there's a potential to actually raise the stakes on the part of those interested in this area. So tomorrow we're going to discuss one series of interventions that come from accentuated political will in terms of making a difference by looking at how one goes about addressing and lowering the barriers to access people have to vaccination sites as a way of driving up vaccination rates. So this can be done. And we have a really good panel tomorrow that will be moderated by Martin Weller from the University of the Witswatersrand in Johannesburg. And as a speaker, somebody who's been on the front lines of getting governments to actually invest in health in a much more organized and effective way, given by Amanda McClelland from the Resolve to Save Lives. And she will then be joined by Claire Cutland, also from the University of the Witswatersrand, Raji Tajuddin from the Africa Center for Disease Control, based in Addis Ababa, and Roland Whelan, who is with Discovery Health, which is a health insurance company operating out of South Africa. And so with that, I want to say, please join us tomorrow. Thank you again for an excellent, excellent morning. I really would like to thank you for investing 2 hours of your time in joining us to tackle this most important issue. And with that, please enjoy the rest of your day. So thanks. Bye-bye.